Welcome, clinicians, to this Explainer series. Today, we are tackling what is literally the most dangerous miss in emergency medicine, the posterior fossa stroke presenting as isolated dizziness. We're drawing directly from the brilliant clinical framework developed by Australian Dizziness Clinics, and honestly, the stakes here could not be higher. When a patient walks into the ED complaining that the room is spinning, you know the pressure is instantly on. So this explainer is designed to arm you with a structured, rapid, rules-based approach to totally navigate that pressure. Let's get right into it.
Here we go with Part 1, Risk Stratification and Red Flags in ED Dizziness.
Okay, first things first, we have to fundamentally reframe how we view the acute dizzy patient. We've got to stop seeing dizziness as just an annoying symptom to temporarily fix with an antiemetic and start seeing it for what it truly is. It is a risk stratification problem first and a treatment problem second. You know, your emergency department disposition actually begins way before you order that first test. It starts the exact moment you frame the clinical presentation. Think about this massive paradigm shift. If you pick the pathway before you pick the test, you rarely miss the stroke. I want you to literally repeat that to yourself because it is incredibly powerful. The most common medical legal claim in acute vertigo is a missed posterior circulation stroke, and it's almost always the result of a patchy exam and unstructured reasoning. By committing to a cognitive framework, picking the correct diagnostic pathway right from the history, you prevent that catastrophic miss.
To really grasp the scale of what we're dealing with, just look at this number, 4 to 5%. That is the chunk of all emergency department visits driven by dizziness. Now sure, the vast majority of these folks have benign self-limiting peripheral vestibular conditions. We're talking your standard BPPV, vestibular neuritis, vestibular migraine. But hiding right there within that massive, mostly benign crowd is a tiny, silent subset harboring life-threatening pathology, like a cerebral hemorrhage or a basilar artery occlusion. Getting it right is routine. Getting it wrong, well, it can kill.
So, the million-dollar question. How do we reliably separate the benign from the deadly at the bedside and do it in just a matter of minutes? Well, we use the TiTrATE framework. This right here is your absolute core mental model for rapid risk assessment in ED dizziness. TiTrATE stands for timing, triggers, and targeted examination. It's this elegant, incredibly effective cognitive tool that basically forces explicit clinical reasoning and keeps you completely anchored to the evidence.
Let's rapidly break down how this works sequentially to just drastically narrow your differential diagnosis. Step 1, you look at timing. Is the onset acute and continuous? Is it episodic or is it chronic? Step 2, you check for triggers. Are the symptoms provoked by a specific action, like a position change, or did they happen completely spontaneously? And then Step 3 is the targeted exam. Notice I said targeted. You don't just do a generic sweeping neuro exam, you execute a highly specific exam tailored entirely to the timing and triggers you just identified.
This is exactly why nailing down those triggers is so absolutely crucial. Think of it like a fork in the road. Down one path, you have clear positional triggers. The patient is totally fine until they roll over in bed, and then boom, the room is spinning. That points you straight down the BPV pathway where you'll confirm with a Dix-Hallpike test. But down the other path, you have spontaneous, continuous vertigo with absolutely no triggers. This puts you in the acute vestibular syndrome, or AVS pathway. Listen, the absence of a trigger in acute, sustained vertigo is a massive red flag. It mandates a rigorous stroke workup because at that point, it's either vestibular neuritis or a stroke.
So once you've pre-committed to your pathway, you execute the targeted exam. This includes assessing unassisted gait, clearly characterizing the nystagmus, checking cranial nerves, running cerebellar testing, utilizing HINTS Plus for your AVS patients, and definitely grabbing orthostatic vitals and a 12-lead ECG. Now, I have to pause here on unassisted gait. An absent gait test is one of the single most frequent documentation failures we see. If you do not test and explicitly document that patient's ability to walk unassisted, you completely pull the rug out from under your ability to defend a safe discharge. All right, let's shift gears a bit. Up to now, we've been happily building our structured framework. But what happens when that framework trips an alarm? We are now entering the domain of the red flags. I like to call these the overrides. These are the high-risk, flashing light clinical features that should instantly shatter any benign impression you might have formed. When these pop up, your disposition immediately pivots to admission and advanced imaging.
The absolute biggest override, focal neurologic deficits. We are talking dysarthria, diplopia, dysphagia, hemiparesis, or truncal ataxia that is wildly out of proportion to their vestibular complaint. If your dizzy patient has literally any of these focal signs, they are reclassified immediately as a possible stroke. Full stop. No debate. This mandates a full stroke pathway activation, an admission, and an MRI. You absolutely cannot safely discharge this patient. Next up, let's look at the eyes.
For those acute vestibular syndrome patients, a central hints pattern is a massive, blinking red flag. What does that actually look like? Well, it means a completely normal head impulse test in a patient suffering from continuous vertigo. It means direction-changing nystagmus on eccentric gaze, or pure vertical nystagmus. Or it could be a skew deviation when you do the cover-uncover test. If you see any of these specific patterns, it means stroke until proven otherwise. And I don't care how quote-unquote peripheral the rest of the patient looks. Which brings us to the ultimate make-or-break functional question. Can the patient actually walk unaided? We touched on gait a second ago, but astasia, which is the complete inability to stand or walk without someone holding you up, is a massive discriminator here. Patients with peripheral lesions, like vestibular neuritis, yeah, they feel absolutely terrible, but they can usually walk with a bit of support or a really wide stance. Patients with central lesions often simply cannot. Astasia is a hard, concrete barrier to safe discharge.
We also absolutely have to factor in the patient's underlying physiology. Imagine two totally different patients. Over here, a 35-year-old with zero medical history, and over there, a 65-year-old with hypertension, AFib, and diabetes. Vascular risk factors, especially when combined with being over 50, drastically jack up the pretest probability of a posterior circulation stroke. In that older, higher-risk group, your threshold for ordering advanced imaging like an MRI should be on the floor. You simply have zero tolerance for diagnostic uncertainty with them.
Let's see how all of this actually builds into real-world disposition decisions. Notice how explicitly combining the clinical scenario with the exam findings practically makes the decision for you. Young patient with classic BPV? Easy. Discharge with an Epley maneuver and some PT. But look at acute vertigo in a patient over 60 with hypertension. Even if your exam feels a little equivocal, that combination alone demands admission for imaging. Vertigo with headache and ataxia? Admit them. Rule out a cerebellar hemorrhage. Syncope with a weird ECG? Admit to cardiology. The rules are crystal clear.
All right, let's wrap this up with 3 absolute gold standard clinical pearls to anchor your practice. Number 1, TiTrATE forces explicit reasoning. It gets you out of the guessing game and into a rock-solid diagnostic pathway. Number 2, right at the bedside, a properly performed HINTS exam plus a gait assessment actually outperforms an early CT scan for ruling out a stroke. And number 3, any red flag, especially age combined with vascular risk, completely overrides any benign impression you had. Just remember, crystal clear, structured documentation of your differential, exactly what you considered and what you ruled out, is your absolute best medical legal defense.
Nailing this risk stratification? That's really just step 1. In part 2 of this explainer series, titled Safe Discharge and Documentation, we are going to take the patient who has actually passed these risk tests and turn them into a totally defensible ED disposition, covering the exact criteria, the clinical notes, and the specific safety net advice you need. But before we wrap up, I want you to ask yourself a question. The next time a dizzy patient walks into your ED, are you just going to treat the symptom, or are you ready to catch the stroke hiding in plain sight? Thank you so much for joining me for this explainer. To dive into more topics around dizziness, vertigo, and imbalance, and to grab some amazing clinician and patient resources, head over to AustralianDizzinessClinics.com. Oh, and please subscribe and leave a rating if this was helpful for you. Catch you in the next one.